Good evening, everybody. So, this was the abstract presented at ESCO, and this study is still ongoing. So, background: Osimertinib is the standard first-line treatment for EGFR-Mutated advanced NSCLC, and about 20 to 30% of the patient do not respond to Osimertinib. So, there is a great heterogeneity that has been observed. There is no clinical or molecular predictive marker are currently available to identify those patients who needed different therapeutic approach, possibly including a combination with other agents. So this study actually was done with EGFR-mutated advanced NSCLC patient who received Osimertinib as per the standard of care, and then they have collected plasma sample at T0, T1. That is after 10 days of treatment, after 28 days of treatment, or at radiological progression. They have also done EGFR by RT-PCR in order to evaluate variation of EGFR mutation in plasma during treatment. T0 and T3 samples were also analyzed for next generation sequencing, and tissue biopsy were performed at baseline and at the time of progressive disease are collected for parallel NGS analysis. Clearance of EGFR mutation at T1 and T2 points to associate EGFR variation in plasma with outcome endpoints were analyzed. So this is the study design basically. They have done a tissue biopsy for EGFR mutation and also NGS analysis on the tissue. At day 1 they have done liquid biopsy, real-time PCR and NGS analysis. At day 10 they have collected liquid biopsy for real-time PCR. At day 28 liquid biopsy for real-time PCR, and at progression again liquid biopsy, tissue biopsy, NGS analysis and tissue NGS analysis they have done. And what was the objective of this study is to depict the genetic heterogeneity for EGFR mutated patient in tissue and plasma, to confirm the role of longitudinal liquid biopsy in predicting clinical benefit, and to explore potential genetic alteration associated with primary and acquired resistance in tissue and plasma. So this is the baseline characteristic. Mostly the patients were female, non-smoker, with ECOG performance status more than 1, adenocarcinoma patients, and most of the patients were either 4A or 4B with less than 2 metastatic sites. The most common mutations were deletion exon 19 and L858R, which is very common, but they have also included rare mutation and compound mutation, which constitute around 12% of the patient. Then the treatment outcome, you can see that around 60% of the patient has some clinical response, and around 50%, that is around 75%, has some disease control. The disease progression was seen in 12% of the patient, and 86 around patients were alive at this point. Then this is a summary of molecular analysis being performed. At T0, around 23.4% doesn't have EGFR, T1 53.3, and at T2 0.76 had cleared the plasma by RT-PCR. So this is the chromosomal abnormality. You can see the example. Those who have stable profile, you can see there is not much of variation. Those who have unstable profile, there is much of variation, and those patients who have EGFR amplification, you can see they have exon 19 amplification. So there is some instability over there. Then the result was presence of EGFR mutation in plasma at baseline was associated with increased tumor burden. So those who have EGFR mutation at baseline have more tumor burden, that is more than 2 metastatic sites. Those who have clearance at T2 have more probability of radiological response, and all patients experiencing PD, progressive disease, had no clearance at T1 and T2 endpoints. Presence of TP53 mutation, as you can see in the table, at baseline is associated with reduced probability of radiological response with the treatment. So what are the conclusions right now is preliminary data confirm the feasibility of systemic evaluation of genetic heterogeneity in EGFR mutated patient in plasma. Real world analysis confirms the reproducibility of association of EGFR mutated clearance during treatment and response to treatment. At baseline, about 1/3 of analyzed cases carries TP53 mutation, and there was reduced probability of treatment. And the study is still open for enrollment. Paired NGS analysis and tissue and plasma at T0, T3 are planned to explore potential mechanism of primary and acquired resistance. So still that data is not available. What was the exact mechanism of resistance? Thank you.